introductions? Thank you, Jenna. Okay. All right. So welcome to the School of Health Information Science at the University of Victoria. This is our seminar series. And today we're excited to have a presentation on the BC Gender, Sex, and Sexual Orientation Health Information Standards, which has been recently released. We have two speakers for us today who will be tag teaming it. So we have Kelly Davison, and we also have Desmond Guarin. So as we begin, I would like to acknowledge that we here at the University of Victoria are situated on the lands of the Lekwungen speaking peoples, in particular the Songhees, Esquimalt, and the Wasanich peoples. And we have the privilege of working, living, and playing on their lands. I'd like you to take a moment and think about where you're joining our call from today. And as we move forward in working in digital health, I hope that we are able to think about how our work can affect reconciliation and also digital health equity as we move forward. So to get started today, I'd like to introduce our two speakers. Desmond is a senior business analyst in health information standards with the Conformance Integration and Standards team at the Ministry of Health here in the British Columbia. His current focus is around standards governance, business processes, and stakeholder engagement. He's gained experience in healthcare at the clinical level and medical imaging, as well as the administrative level in finance and business planning. And I'd also like to welcome our second speaker, Kelly Davison, who is a CNA certified psychiatric and mental health nurse, and also is certified in health terminology standards as a specialist. He's graduated, so some of you may recognize him, from the University of Victoria School of Health Information Science double degree program. So that's a master's in nursing and a master's in health informatics, and also our graduate certificate in the health terminology certificate program. Kelly is currently engaged in doctoral studies here with us at the school, and his research interests include structural stigma and modernization of gender, sex, and sexual orientation information practices. And he's a member, a well-respected member of our UVic GSSO research team, and he's also worked as a collaborator on this particular standard. And so I'm going to go ahead and turn this over to our speakers, and I believe you're probably going to go ahead and share the screens. Yep, it looks like that's already in progress. Okay. Do you want questions before, during, or after?
Let's keep this informal. I think during, if questions arise, please feel free to chime in. I'm just going to share my screen here, so let me know if you can see it, okay?
Yep, it looks beautiful. All right, I'm going to go ahead and put myself on mute, and I'll be watching the chat box in case anybody wants to add a question but doesn't feel comfortable with their microphone. Thanks.
Okay, thanks.
Thank you. Can everybody hear me?
Loud and clear, Desmond, thanks.
Yes.
Great, thanks, Kelly. So my name is Desmond Guarin, and I'd like to also acknowledge that I'm thankful to live, work, and play on the traditional territories of the Siyanu-Suk and Malahat First Nations, which is more commonly known as the West Shore of Greater Victoria. Now, these First Peoples have cared for this land since time immemorial, and their stewardship and connection continues to this day. Secondly, I'd like to also thank the organizers of this seminar for the opportunity to present this important work to you. So as Karen mentioned, I'm a senior business analyst on the Conformance Integration and Standards team at the BC Ministry of Health. We have a team of three that is supported by subject matter experts such as Kelly Davison, and the three of us focus on health information standards. And as Karen mentioned, my role in the team is around standards governance, the business process, and stakeholder engagement. So the Gender, Sex, and Sexual Orientation Health Information Standard was developed over the last 2 years. And we had participation from key stakeholders across the province, namely Transcare BC, the UVic GSSO project team, as well as various standards and health information exchange working groups. Feedback was also provided by Pan-Canadian and international standards experts, organizations, and working groups. Now, this health information standard, and I emphasize health information, is specific to the healthcare sector, and it also aligns with the recently published Gender and Sex Data Standard, which was put out by the BC Data Service at the Ministry of Citizen Services. The intent of the GSSO HI standard is to support inclusive, equitable, and quality healthcare in BC. And this is going to be done by applying a consistent approach for modernizing GSSO information practices. And ultimately, we hope it will result in improved delivery of provincial health programs and services. So in short, the standard represents a modern, inclusive approach to health information standards, and it promotes the integration of a wide range of health and social services. So I'm going to pass this presentation over to Kelly Davison, who's going to unpack the details of the standard, which include information about the standard representation, as well as the collection, sharing, and use of data in a connected continuum of care. Over to you, Kelly.
Thank you very much, Desmond, and thank you very much, Karen, for the introduction. I saw that you have a poster there for the Graduate Certificate in Health Terminology Standards. I did take that, and it's served as a wonderful foundation to my career so far. So I'm really glad I took it, and it's enabling all of this structural change that we're working together to make. Just going to move the slides here. So what's the sort of problem that we're dealing with here? So the context is that sex and gender, which are two different concepts, are very commonly misunderstood and they're conflated. This includes within digital health information systems and in BC, which is of course the scope of this discussion. This can be attributed to a lack of adequate specification in terms of data element names and definitions, including the role of observations within those data elements, lack of guidance for how and when to use or not to use different data elements, lack of specification when it comes to code systems and standards and value sets. Our subject of care standard in BC is outdated. And then, of course, we've got fragmented implementations, which are dictated largely by application providers and vendors. So right now, it's sort of like everybody's conflating. I shouldn't say everybody. Many systems are conflating sex and gender. I'm talking about social systems as well as digital health systems. And then there's sort of a patchwork of vendors. This makes it very difficult for interoperability, which is a word that's close to my heart, to happen. So what's the result of this conflation? When we conflate administrative and clinical, gender and sex data, we get direct and preventable harms, namely outing, misgendering, and misnaming people. Those are avoidable harms. We get human rights contraventions, and this doesn't just pertain to transgender individuals who have the fundamental human right to not be discriminated against in healthcare or anywhere else for that matter. But also there are some interesting implications for cultural safety and working with Indigenous people in healthcare as well. This leads to avoidance of healthcare. When people are harmed by healthcare, they don't feel safe accessing healthcare, whether it's physical safety, psychological safety, emotional safety. They tend to avoid it. And when people avoid healthcare, they're not always getting the proper treatment that they need or screening that they need to prevent diseases that are they're at risk of developing. So as a result of that, health inequities happen. Conflation of administrative and clinical, and I'm going to say and sex and gender data constrains functionality in EHRs, and as well as it sort of constrains quality of care. Right now in most systems, we're using administrative gender and sex data elements in the clinical setting for clinical care. And that has turned out to be problematic for some people. It limits the ability of clinicians to distinguish and effectively use the concepts. So, most clinicians and most business people and most students are becoming more and more aware of the importance of gender and gender identity in social settings and society at large. And so we have this movement away from the conflation, the social conflation of sex and gender, into something that separates them, so that we can interact with people more honestly and affirming. It can compromise identity matching through inaccurate demographic data, and of course can impair social inclusion. So the idea is that if our structures are inclusive and affirming, our cultures will be inclusive and affirming. When healthcare workers have access to specific information about a person's gender expression, such as their pronouns, the name they wish to use, their gender identity, they can prevent the harms that I discussed earlier, namely misgendering, dead naming, and outing, all of which are barriers to access, as we've discussed, to folks who may avoid healthcare because they experience them or feel they're at risk of experiencing them. So having this information creates safer spaces in healthcare and safer cultures. It improves the quality of the therapeutic relationship from which arguably all data arises, and it counteracts the effects of stigma, homophobia, transphobia, and gendered violence. By implementing this standard, providers and organizations can cultivate cultures of acceptance and inclusion within healthcare while supporting the fundamental human rights of all people. And we can see from this diagram that it's sort of like a self-perpetuating cycle. When gender diverse people avoid healthcare because they're being misnamed, misgendered, or outed, they're missing opportunities for preventive screening. And actually that's you know, in my mind, that's on the fault of healthcare. As a result, they face inequities, and inequities develop. And so it's a sort of a self-perpetuating cycle. Some drivers of this standard include, of course, human rights. So the Canadian and the BC Human Rights Codes include protections for gender identity and gender expression. This standard aligns with the recommendations from the BC Office of the Human Rights Commissioner. The BC Public Service is also driving this. So they use a gender-based analysis plus requirement for privacy, program and legislative processes, and of course, the Gender Equity Office and the Office of the Chief Information Officer. We want to modernize these practices. So clinicians, health authorities, and EMR and EHR vendors have requested modernization of gender and sex components. And we want to enable effective reporting in clinical care, because it requires accurate information about a person's gender, sex, or sexual orientation. And that's at all levels, you know, at the bedside, through systems monitoring, through public health surveillance, and through program performance measurement. This standard is a catalyst for transformation and will enable changes which will improve public health and pandemic monitoring and response, health outcomes for diverse communities, including 2S LGBTQ+ people and Indigenous people. Furthermore, development of technical artifacts to support the standard, like subsets, ref sets, value sets, will open up new areas of medical research and enable personalized medicine for all people. Anatomic inventories, surgical inventories, sex-related medication statements, etc. So this standard is not simply about sex and gender. It's about demonstrating leadership in a time of uncertainty and enabling quality healthcare for all British Columbians. And I'm sure you've seen in the news time and again examples where certain parts of the world are demonstrating how not to be inclusive and how not to value all people. We want to avoid that. So how did this standard develop? Essentially, this is a data standard based on international standards, including some of the health, the controlled terminology standards like SNOMED, CT, MOIC, and HL7 International, so the exchange standards. It aligns directly with strategic initiatives for transforming primary and community care settings, advancing analytic capabilities, and enhancing foundational clinical systems to support and enable health sector priorities, affirming care being one of those. And this is actually a really important point, because it's modernizing these concepts and these practices is intended to sort of support the therapeutic relationship and improve and enhance that. But that's not the only place where I could say practices, culture needs to change. If you think about how analysts view and interpret these concepts and use them to make decisions, statistically or otherwise, they need to understand the difference between sex and gender and what the implications of conflating or aggregating those concepts are, and also how to use and how to view the variation that exists. So like multiple gender identities, for instance. This framework is based on the OCIO, which is the BC Data Service, Gender and Sex Standard for Government, as Desmond mentioned. It aligns with Statistics Canada Gender and Sex of a Person standard as well. We developed this as a pan-Canadian standard with input from various provincial health sector stakeholders, and they're all aware of it. We developed it with Canadian jurisdictional partners and international partners, and will continue to work to develop the artifacts to support this standard with them at a pan-Canadian level. The idea is that one day soon, we will have ref sets and subsets for gender identity and the other data elements available at a pan-Canadian level, and having had input by different jurisdictions. This standard provides framework, concepts, definitions, and guidance for the selection of technical artifacts, such as concepts from controlled medical vocabularies, which are used to share data between health information systems, usually via an HL7 exchange standard. We need to modernize principles, policies, processes, and information practices that include defining, collecting, organizing, exchanging, and using these concepts. And then there's, like I said, ongoing work in the development of the standard and the artifacts to support it. And it's all been done in accordance with the recommendations from the Office of Human Rights, and I think for the right reasons. Some of the stakeholders that were involved in the development of this standard. So we've got the Office of the OCIO, Transcare BC. We've got the GSSO Modernization Project, or the GSSO Research Team from the University of Victoria. So that includes Dr. Karen Courtney, Dr. Francis Lau, Dr. Aaron DeVore, myself, and that team is growing and expanding. So anybody with a keen interest in digital health equity is really interested in this work, and it's ongoing. Francis, Karen, and myself are co-chairs of Canada Health Infoway Sex and Gender Working Group. And so we've been working with that whole working group, which includes, organizations, jurisdictions from across the country, people with lived experience, researchers, both national and international, all sorts of people coming together to develop the components that have been incorporated into this standard. Clinical advisors like Dr. Bill Clifford, and then folks who look after our data standards at CAI-HI. The standard has been endorsed by the Health Information Standards Standing Committee, the Digital Health Strategy Office, the OCIO, and has been reviewed and multiple times by the UVic GSSO Action Plan team, which is the research team. Gender affirming care is taking a prominent place in clinical guidance in response to increased social awareness of gender diversity and human rights. And as I said earlier, trans care and trans rights are central to this change and are driving this change, but this change has implications for all people. Indigenous people, the general population as well. So it's not limited to the care of transgender people, but it very much is being driven by it, and by our common values, by fundamental human rights that we've outlined 80 years ago now, and are starting just to sort of act on. So what are the requirements? So the requirements for affirming care include affirming interactions, and the data elements in this standard that support affirming actions or interactions include name used, pronouns, and gender identity. When we wrote this standard, we agreed that while this does pertain specifically to digital health systems, some of these data elements and the way they're conceptualized in the standard could be implemented socially as well. So you can use the name that a person wants to use, you can use the pronouns that they want to use, and you can know about their gender identity in social settings without ever putting your hands on a keyboard. So part of this is social change. It's a socio-technical change. And then, of course, you've got the administrative and clinical data elements, and we need to separate those so that we're not using administrative data elements in the clinical setting or for clinical decision making, because that can lead to problems. Administrative data elements include administrative gender and the Health Services Sex and Gender Marker in BC. Clinical side, we've got a new or novel data element, sex parameter for clinical use, and then, of course, sex assigned at birth. The standard addresses the socio-technical change necessary to realize the vision of health for all British Columbians and supports government directives to better address the socio-economic determinants of health, such as gender identity, sex, and sexual orientation. It outlines modern information practices and needed functionality changes for administrative and clinical data elements necessary to innovate personalized medicine, improve granularity and quality of data collected at the bedside, as well as enhance the analytics that measure care quality along sex and gender stratifiers. Finally, it positions the BC government as the national leader in inclusive care and adheres to anti-discrimination legislation. Just for a bit of background here, and more to come on this, administrative gender represents the gender identity that a person wishes to have recorded on legal documents, or the gender identity that a person identifies with for the purposes of interactions with official agencies. HSSGM there, which is Health Services Sex or Gender Marker, is the documented gender or sex of an individual used for clinical, official, or legal purposes where only one data field exists. So legacy systems mostly. SPCU, which is sex parameter for clinical use, is a novel data element, and it's one that's being developed and validated by HL7 International, in particular the Gender Harmony Project. So that's something to note if you're interested in this work. We need Canadian participants in these standards development groups. Most of them are open. So SPCU was designed to enable clinicians to specify additional context to support clinical decision making and interpretation for clinical orders. Sex assigned at birth is a data element that includes options for assignment of the sex of a person at birth based on the clinical observation of biological characteristics. So when we wrote this standard, we wanted to make it high level enough and accessible enough through plain language, supportive diagrams, and helpful guidance that would be useful widely. Technical folks can get pretty technical, and there is a technical side to this standard, but largely this is about understanding the importance of the social change necessary for affirming care. Key implementation guidance for this. Sex and gender are two distinct concepts. The administrative data elements may be inappropriate for clinical care. Gender identity may be identified by the patient, must be identified by the patient. It shouldn't be identified by anyone else. No one can say to me, your gender identity is a man. How do they know, right? Just based on how somebody looks. We know that people present, their gender expression can change from setting to setting, and that can be fluid. Gender data should be collected and displayed by default, and then sex parameter for clinical use should be used to provide additional context when required We've pulled together a lot of evidence into this standard. We've published papers, we've drawn from researchers, and the recommendations are evidence-based. So the standard is divided into 3 parts. Part 1 include the data elements for affirming communication. I talked about this just a second ago. So this is sort of the social aspect. Of course, digital health systems can accommodate these data elements, and it's important that they do, so that providers and care teams can interact with patients in an affirming way, and can avoid, the said harms of outing, misnaming, and misgendering. So name used is a data element in this standard. It's specified by the patient, and it should be used in the context of healthcare. Pronouns are linguistic tools, and you'll see them more and more in people's emails, and even in Zoom settings. Like, what pronouns do you use? Like he, him, she, her, they, them, he, they. What pronouns do you use? So they refer to people instead of using the person's name, a noun or a noun phrase. And gender pronouns are third-person pronouns that reference a person's gender identity. So like I said, he, she, they, and they're part of gender expression, and they can change. Gender identity is an individual's personal experience of being a man, woman, non-binary, or something else. People may identify with more than one gender identity or use different gender identities in different settings. Here is sort of a conceptual or information model. It's got cardinality. These are the data elements. It also has the value options beside it for helpful reference. In the text of the standard, we make direct reference to, maybe it's a LOINC standard, maybe it's a SNOMED CT concepts, maybe it's an HL7 standard. We make direct reference to the ones that we think people should be using for these, and that include the value options. And so it should make it easy for people who are implementing this to make a decision on what code systems they should be using and which options they should be using. Some are still under development, and that's just part of the process. Part 2 of the standard is administrative gender and sex. So as I've said before, HSSGM is the documented gender or sex of an individual used for clinical, official, or legal purposes where there's only one data field in the system. And we've got sex assigned at birth, which are options for assignment of the sex of a person at birth based on clinical observations, and then administrative gender. And importantly, this is the gender identity that a person wishes to have recorded on legal documents, or the gender identity that a person identifies with for the purposes of interactions with official agencies. And this is important to consider because not everybody wants to be out to the government, okay? Sometimes it should be limited to healthcare, and people should have that option. Here is the sort of conceptual model of these data elements. Again, reference to cardinality and value options, all pointing to the appropriate standards within the document itself. Part 3 of the standard refers specifically to sex parameters for clinical use. Now this, as I said, is a novel data element. It was designed to enable clinicians to specify parameters that support decision-making and interpretation for clinical orders. It does this by alerting clinicians and technicians to refer to specific artifact or clinical parameters such as sex-related anatomy, a sex-related medication or hormonal inventory, a surgical inventory, or other useful artifacts. Most of these artifacts are not yet standardized and need to be developed and standardized, and that's our ongoing work. And so the options for sex parameter for clinical use, after much debate, include sort of a typical female, and that would point to typical female reference ranges, for instance, typical male, and then something that a clinician can specify. So if in cases where a female typical or male typical option is inappropriate, and the clinician needs to give specific direction or point to some other artifact that provides necessary context, they can do that. And they would specify to a sex-related anatomic inventory or a surgical inventory or a hormone medication history or medication statement, or any number of artifacts that have yet to be formalized and developed. This is conceptually what it looks like, and I did this diagram because this is sort of the way that I think. It's got the data element there, the cardinality, so this can be specified on every single order or different orders, and you can have different artifacts be pointed to through this specification. Importantly, in this diagram, you see the cardinality of the inventories is like only one, so it's something that needs to be standard, and once it exists, there should be one that exists for the patient, and it should be updated regularly and be accurate. So the Sex and Gender Working Group, we're starting to get into some of the design considerations for sex for clinical use, sex parameters for clinical use, and the discussion is actually really interesting. And so as we move forward, we're going to figure out how this data element should be used in terms of best practices, what artifacts need to be developed, what practices are required to ensure that the artifacts are used safely and the data element is used safely, what sort of cultural considerations we need to add. And then we have sexual orientation, which is, of course, a very important part to everybody's identity and health. We've added here, a list of potential options. There aren't currently any hard standards related to the collection, use, sharing of this information, but we know that, especially from the work of StatsCan and CAHI, sexual orientation is used broadly, and research too, to identify disparities between populations, especially between cishet folks and gender diverse folks or sex and gender minorities. And so so we know this is important, and I think we have a lot of work to do in terms of thinking about and establishing how it should be used, when it should be used, when is it relevant to healthcare, right? When data should be collected, etc. So you put all those pieces together, and this is sort of what you get here. You've got all of these different data elements related to a person. One that I haven't discussed in any of the slides is this negative experiences. So it's the top right-hand one. We know that people have negative experiences in healthcare, and I think it's important to begin to document that. And so, concepts to support negative experiences will be developed soon. They're underway. And so we have all of these data elements coming together in sort of a harmonious framework. We've got all of the value options listed, and I think this is a pretty useful model for folks who will ultimately be implementing this standard and thinking about it as well. This standard is aligned with international, national, and provincial standards, including ISO 27527, which is health informatics or provider identification, ISO 22220, which is identification of subjects of health of care, ISO 9143, Open EHR, basic formal ontology, HL7 gender harmony model, which is largely where this is modeled after. StatsCan, CAHI, Sex and Gender Working Group, and the BC OCIO framework. I see there's a comment in the chat here. Oh, thanks,
I just
Karen.
put the link in, sorry.
That's great. So folks, if you want to see the document itself, just click on the link in the chat and it'll take you right there. So this standard, when implemented, means big changes. It might be adding a data element here and there, but they're sort of fundamental data elements. and a fundamental shift in the way we conceptualize sex and gender and the way we use it socially and also in healthcare. It's going to require changes to messaging standards, and those have already started. And it's going to be, I think, a driver of digitization of health records. And that's simply because most paper records have what we would now consider inadequate specification or representation of gender, sex, and sexual orientation on them. It's going to require changes in digital health systems, including electronic health records, EMRs, portals, case management systems in BC. Some of the identity management infrastructure, we're going to require changes there. And of course, the development of different artifacts to support clinical care. So with the way that I'm thinking about things with this standard is that sort of creaking the door open to more personalized medicine through gender and sex, because once we have standardized artifacts, we can start to build rules and clinical decision support around those. Our data will get more and more granular, and we'll be able to explore new and innovative ways to provide personalized care, culturally safe care for all people. So modernization will require a coordinated effort because it will impact most digital health systems and care cultures in BC. The impact is cross-cutting. The change will draw in health authorities, specialty programs, research institutions, and different portfolios within the health sector. There are dependencies that will require parallel work, so like the MPI, vital stats, digital health solutions, for instance. Messaging standards, all this stuff is sort of happening and will have to happen at the same time. So there's going to have to be a lot of crosstalks that we don't deviate. With strategic planning and support, that can be done. The Ministry of Health can leverage key assets to drive the necessary change and evolution. And then knowing that the standard is complete and groundbreaking, BC has a foundation to move forward on a whole of systems change. And it'll require an agile approach and adequate resourcing. We're going to have to develop guidance documentation, technical specs. We're going to have to operationalize and publish, value sets and ref sets and subsets to support the adoption and implementation of this standard. Messaging standards will change, and so with all the support that we have from within the team, from externally, stakeholders, we're in a good position to strengthen our public health reporting, our pandemic response, and just overall, set BC forward as a world leader in healthcare quality and innovation in specific regards to gender, sex, and sexual orientation. And I don't say a world leader lightly. The standards that we are working with in BC are international, and they require participation and input at an international level. So SNOMED CT is international. HL7 International is international. These conversations are happening on an international level. ISO, TC215, that's international. And so we're bringing the international stage to BC in this standard, and also we are innovating in that. As far as I know, this is the first jurisdiction to outline a comprehensive standard and guidance in Canada. A short list of affected systems. So if anybody works on these systems, this is just a heads up. Of course, the vendors, EMPI, Vital Stats, PharmaNet, CareConnect, Panorama, the Surgical Patient Registry, MSP, Acceleris, any research interfaces, the ICM, and then CAI submissions will be impacted as well, and then DICOM and medical imaging. In terms of next steps, we're working on a health sector-wide strategy, starting with HIE system adoption, in particular the EMPI. We are going to continue to develop, and we'll need lots of help and support because it's lots of work to develop technical artifacts to support the standard. These include the subsets, reference sets, value sets. to ensure interoperability and connected care continuum. We're going to engage in a minimum viable product process with stakeholders, which include the health authorities and vendors. And we're going to continue to collaborate with clinicians and health authorities and vendors on clinical guidelines and implementation guidance. And so we've got a long road ahead, but it's going to be an interesting journey, and we're very much looking forward to it. And so with that, I'm done my presentation, and I'm happy to hear any questions or comments you might have.